topics and opinions expressed in the following show are solely those of the hosts and their guests and not those of W4CY Radio, its employees, or affiliates. We make no recommendations or endorsements for radio show programs, services, or products mentioned on air or on our web. No liability, explicit or implied, shall be extended to W4CY Radio or its employees or affiliates. Any questions or comments should be directed to those show hosts. Thank you for choosing W4CY Radio.
Inarticulate speech, inarticulate speech of the heart. Inarticulate speech, inarticulate speech of the heart. Inarticulate speech, inarticulate speech of the heart.
Hello, and welcome to It's Your Voice, the show that hosts enriching conversations in diversity. My name is Bahia Yackzan. I am a core alignment coach, an emotional wisdom training specialist, and a diversity educator. If you're interested in seeing the programs that I design and train to individuals or groups, whether it's coaching or anti-racism or anti-oppression trainings, or how to communicate across differences, you can find my programs at knowwhatyouvantcoaching.wordpress.com. Today, I have a special guest who's very close to my heart. His name is Dr. Daniel Yackzan. He is a resident surgeon in his second year of residency. He studied neuroscience in undergrad at Vanderbilt University, and he completed his MD at the University of Kentucky College of Medicine. And we are going to talk about a variety of topics. And I also want to just begin by thanking all providers who've been working extra hard during this pandemic, including Dr. Yackzan in his residency. So Daniel Yackzan, thank you for joining me today.
Hey, thanks for that introduction. I'm happy to be here.
I was going to ask, did I pronounce your name correctly?
Yes, you did. Yep. I like your last name, by the way.
Oh, thanks very much. I happen to have a picture of you from 5th grade, I think, because you're my nephew. Just wanted listeners to know that's super smiling and super proud. And you do work so hard. And I wanted to, before I start asking you questions, can you tell us more about what is involved? Like, I know you did 4 years undergraduate.
Mm-hmm.
I did 4 years of medical school. And you completed your MD, and you're in your second year of residency out of 5 years because you are in the process of becoming a general surgeon. So can you tell us about residency and rotations and how long they last? And
yeah, absolutely. So yeah, you nailed it. The progression there. So you go to undergrad, and then you go to medical school for 4 years, and then it's residency. Residency is variable in its duration. It depends on what type of physician you're training to be. A lot of the medical specialties like emergency medicine, internal medicine, family medicine, those will be 3 years of training, and then you go into any fellowships at that time. General surgery, I think orthopedic surgery, ear, nose, and throat surgery, I think those are all 5-year residencies. And then general surgery definitely is. And then after that, you go into any specialty fellowships. Neurosurgery is a 7-year residency, and then you go into fellowships after that. So the length of training varies a lot. What isn't so variable is how much work you're doing during those years. The hours are long. It's very consistent, especially among surgical specialties. I think the hours are especially long. It's just more work in the hospital than can be handled in a 40-hour work week. That's essentially what it is. You're just there until the work's finished. But it's a very special time of a lot of growth, I think. Where I was a year ago in terms of taking care of patients and advancing patient care is worlds away from where I am now. And part of that is because of, just how long you are in the hospital. So
Mm.
it's a
Yeah,
process.
it's rare that I get to talk to you because you are so busy, working, and it is a huge commitment. Um, Thank you for that comment. Um, and you share with me that you just don't was you said in an additional way that you can't leave anything loose. You can't leave anything hanging. So
Yeah.
you stay and you stay and you stay. And so it is such a huge commitment. And so what brought you, first of all, into medicine? What inspired you? Who inspired you? And also, why did you choose surgery to become a surgeon?
Yeah. I've gotten asked that question a lot. It's a hard question to answer. I think medicine is a little easier because I was always planning on becoming a physician from the time I remember I initially wanted to be a Blackbird pilot. And then whenever that transitioned, the next one was in second or third grade was becoming a physician. That was always my plan. I liked talking to people. I liked working with people. I liked solving puzzles. I always have. I think the body has always fascinated me. We don't understand everything about it. We won't in our lifetime. Um, it's amazing what it can do,
Mm,
and it's just always seemed like a natural progression to me. Vanderbilt was very pre-medical oriented,
mm,
so they supported me very well there. Um, and yeah, so that's the answer for that one. It just was kind of always my plan. Surgery, I had no plans coming into medical school about what type of physician I wanted to be.
mm,
Third year of medical school, first 2 years are pretty brutal and isolating because it's just studying. You're just in the books and you're going to classes. The third and fourth year are when you do your clinical rotations and you do OBGYN. I forgot to mention that residency earlier. You do OBGYN, you do family medicine, you do internal medicine, you go through all the rotations. And that's when you start to kind of whittle down what you're interested in. And the
mm,
ones I was interested in were all procedural. So I liked OB-GYN a lot. They do a lot of operating. That was the first time I got into an OR. And then the last rotation, my third year, was general surgery. And they
mm,
just had the widest breadth of surgery. They also we also practice medicine, so we manage our own patients. Not that other surgical subspecialties don't. I just think in my experience, it's a little more broad and a little more intentional. A bigger part of our practice is actually managing patients in the hospital, which I wanted to be capable of doing. I also wanted to be the person who was called if a patient is crashing and you don't know exactly what's going on. You get a general surgeon on board. It has
mm,
always been that way, and it is still that way. Sometimes we'll just get calls and say, this patient is his his heart, his blood pressure has dropped. He's on a lot of medicines. We don't really know what's going on. We think
mm,
it may be related to the abdomen. Can you come and take a look? And
mm.
that's very exciting for me.
Wow. And intense. You operate extremely well under extreme pressure.
Well, I'm practicing. It
Mhm,
definitely takes work. Um, or time to get used to it, just to breathe. I see like the attending surgeons, which are like the full physicians, the full surgeons, and they're just so calm, especially the trauma surgeons. That's
mm,
another thing that brought me to general surgery. If you want to be a trauma surgeon, you got to do general surgery residency, which
mm,
is a specialty I'm considering.
mm. Wow, that's interesting. Wow. I wanted to, ask about because I remember when you at one point asking, gosh, in the early part of the pandemic, knowing you were about to, um, complete your MD, I remember, thinking, "Was he gonna be working with COVID patients?"
Mhm.
And at that point in time, I think, um oh, there's a question for you. I will, I'll ask you. Do you see it? What has been your
Yeah,
favorite area of
I
practicing?
can see it.
You can answer that first.
Okay. So my favorite part so far has been my trauma surgery rotation, definitely. running they're called trauma reds at the hospital where I train. I'm not sure that they're called that everywhere, but they're the highest level of traumas that come in the hospital. They're delineated by mechanism of injury generally. So like a car crash at a certain speed is a trauma red versus a trauma alert. And the trauma reds are the highest level. They're most likely to have serious injuries, and those are run by general surgery, by trauma surgery, but by the general surgery residents. And so I've been running those reds starting this year, which is very exhilarating, very nerve-wracking. It gives you an adrenaline rush that lasts for hours. That's been the most fun I've had, certainly. You're basically I'm in charge of the team in the trauma bay and kind of planning the way that the resuscitation goes. So what is the next thing that needs to be dealt with? Do we take them to the CT scan? Do we take them right to the OR? Do I put a chest tube in? Just the order of things. And I'm certainly learning, and I have a lot of backup. I have my chief resident who's right behind me, who corrects me if I'm going off on the wrong path. And then right behind them is the attending, and he, is watching and making sure that we're going to the right path. So there's a lot of oversight, but that has been a lot. That was a lot of fun and terrifying.
Yeah, I guess so. Fun and terrifying. And when you say fun, I'm thinking is part of the satisfaction. I mean, I think you need that to be on that adrenaline, but also, and to be like spot on and clear. But it also is some of the fun, like the satisfaction of like just figuring it out, like seeing the way.
Yeah.
And communicating.
That's a good question. I think part of the fun, or a lot of the fun to me, is that it's so, there's not a lot of interpretation in what should be going on in the trauma resuscitation. We have very specific guidelines I think the term is the Eastern Trauma Society and then the Western Trauma Society. They both have their own guidelines. We follow the Eastern. And, the order that you go down is very specific. So it is tailored to the patient because of what's causing them the most harm is the thing that you deal with at that time. So there's some investigating kind of what the problem is, but the order is very clear. I think it's very fun when I'm getting that right, since I'm still learning it. Also, you make potentially such a huge effect in the trajectory of that patient's life in a matter of like 5 to 10 minutes. And I don't know that there's another instance in the hospital where that amount of time, 5-10 minutes less, can make a difference in whether a patient does very well or does very poorly. I think,
wow.
Yeah.
Oh my gosh, there's just so much. My brain, forgive me, is going back to that question I was asking you, which was,
yeah. What was that?
So I was anticipating that you would not be directly dealing with COVID yourself because you would be in surgery. However, not very long ago, it was in the news that the same small town, and we don't even have to name the town. It's not anyway, a small town in Eastern Kentucky had the highest number of COVID cases, so much that the news station went and interviewed, and the National Guard was called in, and lo and behold, that's the hospital where you landed in.
Yep.
And you have had to deal with helping people survive COVID or doing the best you all could to help them that happen. So can you share a little bit about what was that like and what you did?
Yeah, my experience was interesting because the main portion of our residency is at a large academic institution in Kentucky. And there we have pulmonary ICU doctors that are basically running our entire COVID care at the hospital. So I know which floors the COVID patients are on. Sometimes we're consulted on them, like I was saying earlier about this patient's crashing. Sometimes a COVID patient would crash and they didn't know that it was due to COVID. Maybe it was due to something else happening. So, come up and take a look at them. Or COVID patients have problems too. Like COVID patients have gallbladder disease or appendiceal disease or other problems that we deal with. So I saw them in that aspect. But what I wasn't doing was being very involved in their actual COVID care and the intubation and the lines that need to be placed. So one of the things that we do at this small, and we have a rural rotation. That's what I'm on right now in this hospital.
Right.
What surgery takes care of most of the lines that are placed in this hospital. And by that, I mean arterial lines that are used for dynamic and consistent blood pressure monitoring and arterial blood draws that we use to monitor blood gas. So how they're doing breathing essentially. And central lines, which go into the large veins in your neck or in your groin or in your chest. And those are used for substances that can cause damage to your veins and your vasculature when they're put in peripheral IVs. The larger veins are just more robust and can take more of those medicines. So those medicines I'm talking about are vasopressors, which are used to keep blood pressure up when a patient is really sick. So we're placing all of those lines and chest tubes. If they get sometimes these patients can pop blebs that are in their lungs. And they're on positive pressure ventilation, which can cause this to pop. And if they get air around their lung, they need chest tubes. So we place those in this hospital, as opposed to my big hospital where I'm doing most of my training. Pulmonary ICU does all of that. So I was thrust into this situation where now I'm taking care, or I'm a huge part of COVID patient care 5 or 6 weeks ago when I started this rotation, to the point where my first day, I almost I really had not interacted with COVID patients this much. My first day, we had, I think, 5 or 6 consults for chest tube placement, central line placement, arterial line placement. Several of them were coding throughout. So that means they were requiring chest compressions and ACLS. And some of them passed away. I think 2 of the 6 patients that we were consulted on that day passed away. And it was definitely a kind of a waking up moment, or a realization that, this is very real. I hadn't dealt with it before.
That is very real. And I think that we'll tell stories. We'll have a story in a minute. I just wanted to follow up on this thought, and thank you for requesting stories. Yeah, that's painful and real, and just, again, reflects the pervasiveness and insidiousness of a virus and a pandemic, and that we are still clearly in a pandemic. And yeah, little did we know it was going to be reaching your hands at this point in time.
Yeah. Yep. I was surprised to walk into it. It has died down a lot over the last, so I've been on this rotation for 5 weeks now. So that was my first week. This week, I think I've been consulted on 1 COVID patient this week. So it has died down significantly.
That's good.
Yeah.
And then the National Guard's not there anymore.
Right. Yeah. Yeah.
So,
they were never there while I was there, but I think it was like a week or 2 weeks before I showed up when they had been there.
Yeah, I think that. Yeah. And you mentioned, and I wanted to share that for a while I worked on a public education campaign in rural Maine, in a rural area. And that came to my mind because you mentioned seeing the difference with the diversity and the difference between, huge academic urban hospitals and smaller rural hospitals, even if there's universities, just smaller. And you mentioned something about public education around health issues, and I related to it later because it is a real challenge to get communication out in rural areas. It is very different. But I just wanted, before you tell a story, I wondered if you had any other kind of thought or comment about, like, what you're seeing, like how you can tell as a resident surgeon, how you can see the difference in how much patients have learned about health
Mhm. Yeah,
Or
so at the main hospital that I train at, we certainly take care of these Eastern Kentucky patients, because we're a referral center, so we'll get patients that are very unhealthy, and it's gonna be difficult to induce anesthesia on them or, provide anesthesia care for them during the operation, or because they're very difficult surgeries.
mm,
We'll have those patients referred to us. So this isn't the first time I'm working with Eastern Kentucky patients. However, I am working with them entirely now at this hospital. And I think the biggest difference is what we call healthcare literacy,
mhm,
just the baseline knowledge that they have about the decisions that they make, how the decisions they make affect their livelihood, essentially, and the discussions that we're going to be having about their health. Um,
that's a good word.
that's
Health.
that's the biggest difference is just the baseline knowledge. We can have the
Mhm,
conversations that we have to shift very much to a much lower, a much almost like you're talking to a kind of a younger person, like telling stories about things instead of
mhm,
using words like gallbladder or colon or bowel or things. So,
mhm. Yeah, I think yeah, thank you for that term, and
yeah,
educating me the term, healthcare literacy. Um, yeah, language, and
yeah,
if you haven't been exposed, you don't know it.
right, exactly.
So that's
Yeah, they've never
mhm,
talked about it before. No one has talked to them about it.
mhm. Well, thanks for that too, pointing out how education is part of your work.
Sure.
So, I know, someone's very interested in this story, and it's true. We all love stories. And,
Yeah.
if you can, um, if one comes to mind, or I can ask you about another.
No, no, no. I can come up with one. I'm just trying to decide
Okay.
where to go. Because my most exciting, the trauma story that comes to mind is
Mm,
pretty intense, but I'll tell it. I think it'll be okay. The one of the so like I was saying, the most exciting time I've had during my residency has been on my trauma rotation. I don't know that that's what I'm going to do, but it is the time of the most exciting rotation I've had. One of the patients came in as a red and had multiple gunshot wounds and was crashing. It was a young male.
mm,
And you first you make sure you have their airway intact. So he I don't know if he was intubated or we intubated him in the trauma bay, but you put a tube down their throat into their um, bronchi, and just to to make sure that you're getting air to their lungs. That's the first thing you do, and then you try to find where they're bleeding, basically from the gunshot wounds. So we got an X-ray to find where the bullets were, and actually on this guy, I think we went straight up to the OR. I don't even think we stopped in the trauma bay. I think he was already intubated in the field, and we just went straight to the OR. And so this was like real trauma, and this was on my first week. So
mm,
we I'm wondering if this is too graphic, but we made like a large incision and basically went looking for where the bleeding was. We found several different air places and started working on it. And it's the first time that I've been really involved in a case like that. I put in a central line, like I was talking about earlier, for giving blood.
mhm,
I did it, emergently in the OR. It was just a very intense environment, and one that was very exciting and terrifying, to be honest with you.
mhm.
But
Yeah,
that's
sometimes
what
that's
that was a trauma. That was a real trauma. One of the
mhm.
first ones I've been involved in.
Yeah. Well, thanks for doing the work.
Yeah.
Sounds so intention. On a lighter note, I love to tell our listeners that if they hear some sounds in the background, it's your cute dog.
Yeah, I have a dog and a cat, and sometimes they
This
fight.
dog trying to, be heard in the background.
Yeah.
Thanks. Well, I do know. I know when I used to work with domestic violence victims, we had, thank goodness, we had good supervisors who knew we needed. We could pick up secondary post traumatic stress disorder. So they gave us time to debrief and get clinical supervision so that we could not have to like keep and carry and you know stack on the trauma and carry it around. And I hope do you guys get some like clinical supervision and times and places to debrief after I'm sure not routinely, but periodically,
Mhm.
are there opportunities where that's provided for you to debrief from such like terrifying and I think yeah, terror is sometimes the other side of excitement, you know.
Mhm.
Is there some provision for that?
We have free access to, I think it's like 8 to 10 therapy sessions a year.
Great.
Um, but outside of that, no. But there's not really a conversation about it for
Mm,
us. It's just part of the work. Maybe that's not the best way, but I do think that, the people who choose to go into that work are at least think that they're capable of, or it's something that they're okay with dealing with. Now, I
mhm,
think I think you bring up a good point that I haven't spent a lot of time thinking about. I think that probably there should be some kind of scheduled discussions about how the things that we've seen affect us and affect our view of ourselves and the people around us. The answer is no, it doesn't happen.
mm.
Mm-mm.
Well, I'm glad you think it's a good idea because
Yeah.
I highly believe, like you said, even if it's debriefing with your peers and having a conversation, of course, in respectful,
Yeah.
de-identified, it just helps so much to be able to process and not take it in and carry it home.
Hmm.
But you already know that.
Yeah.
So one other thing, oh, here's a question outside of therapy. How do you cope? Oh, that's a good question. So what do you do to get your stress off and rejuvenate?
I think I don't do it. During the start of residency, I was doing well with exercising and,
Mhm.
eating well and trying to, well, I never slept well. There's no chance to sleep well, unfortunately. If I slept well, it would be the only thing that I did outside of residency. Um, but I think taking care of yourselves in those ways, meditating, exercising, eating
Meditating,
healthy, those are probably the best ways to do it.
and that's the same
Um,
thing.
my dad asked a question.
Oh, yeah. Can you tell us what it's like to receive thanks from one of your patients or just enjoy a few minutes when you have a few minutes? Like with patients. A good
Okay,
question.
wait, let me answer that in a second. I hadn't finished answering the prior question. It was how do I cope besides? Yeah, so I think taking care of yourself is the best answer. Not that I do it that well, to be honest with you. I guess I do. I decompress and spend time with my girlfriend and watch TV. Um,
Mhm, mhm.
but it would probably be better. I should find some more time to exercise. As far as like mentally and emotionally coping, I think that um, a big part of it, unfortunately, is a lot of people in the medical community, me included, and probably surgical community more so, kind of depersonalize from the situations that are happening.
Mhm.
It's a lot easier to think of the patients that you're dealing with as kind of removed from and different from people that you know in your lives, like your family and your friends and your girlfriend. They're somehow different. They're
It's
your
a
patients.
it's a coping mechanism.
Yeah, I think it is a coping mechanism. I think it happens very naturally. Um, and I think that, you know, it's ingrained in the culture that it happens that they're somehow different. It's a little bit depersonalized. And I don't think that it's the best thing to hear as a patient that happens, but I don't know how else um, we would survive going every day to work, especially trauma
Yeah.
surgeons that see just the worst of humanity. They see car crashes and they see accidents like horses stepping on people. Well, that was pretty a
Mhm.
Kentucky example, but and then they see gunshots and knife wounds and
Mhm.
domestic abuse and child abuse and things that nobody
Mhm.
should have to deal with all the time. So
Yeah.
I think that's the unfortunate answer is a lot of kind of depersonalization and
Mhm.
acting like this isn't happening to this is different somehow than the people that you know.
Well, in defense of that coping mechanism, um, I think that it does benefit us if we're your patient because it enables you to keeping the objectivity you need to do the job that you have to do.
Mhm.
So there's the other side of it. And I'm sorry, I didn't see that last question. Did you catch that question that
Yeah,
she said?
she was thanking me. Thank you, Rachel.
Yeah,
I appreciate
yeah,
that.
yeah, it must be difficult, and yeah, he's a superstar. Yes.
What was Joe's question? There we go. Can you tell us what it's like to receive thanks from one of your patients or to just enjoy a few minutes when you have a few minutes talking or interacting?
That's cool.
Yeah, that's a really good question. The first time the reason I laughed a minute ago, I thought he asked, "Can you tell me what it's like to spend a few times minutes with your parents?" I thought he was asking about himself, which is something he would do. Um, hey, Dad. But that's a really good question. I think that in general, patients, I don't know if I'm just being, you know, maybe I'm being a little sour, but in general, it's kind of like an expectation that we take care of patients when they come in the hospital and they're sick. And it's fair, it's the decision that we made and we enjoy doing it. But there's oftentimes not a lot of gratitude. And
Mm,
I guess what I'm getting to is when it does happen, it means a lot in the whole team. Like we'll
mm,
talk about it outside the room when we walk out about how sweet that person was and
mm,
how nice they were. It actually affects our day a lot when someone is very thankful for what we did, for staying until 9 p.m. when we were planning on going to dinner maybe later so that we could operate and get their appendix out or their colon out or whatever
mm,
needed to be done that night. Um, and so it goes a long way. Talking to patients, just in general, spending time with them, I do enjoy doing it. It's the problem is I have so much stuff backlogged generally to do in my day, like writing notes or putting in more lines or getting to the OR quickly and writing the operative report after, all this just stuff that needs to be done that I'm not able to be present often. When I am, it's kind of when there's a character of a patient and they're being really funny or really wild or really mean. I mean, just something abnormal. It kind of kicks me into the present a little bit.
mhm,
And I'm able to appreciate it a little bit more. The other time is if I'm just not busy, there's a miraculous day where I don't have a big backlog,
mm,
then I'm able to spend more time with patients. And I do actually really enjoy that. I was thinking about that the other day. I had a consult, or a consult is when another medicine or another team in the hospital has surgery for their input on a patient. I had a consult where I didn't have a lot going on besides that, and I got to sit down and talk with them. And as I was walking away, I thought that was nice to do.
nice, thank you. Before you answer that question, I wanted to, emphasize for anyone who is listening, because we have listeners on the radio and also watchers on the
Mhm.
TV. Let's remember what Daniel said, how saying thank you to providers makes their day and goes a long way. And thank you, other Yackzan, Joe Yackzan, for that question because
Yeah.
it's such a great point because um, gratitude is just so energizing and you so deserve it. So I'm really glad for that question and thank you for that
Yeah.
honest answer that it really like to picture, wow, by thanking my provider at my next visit, that could really pick up that person's day and
It
they could
will.
even talk to colleagues about like, wow, that patient just thanked me.
It will. I promise. Yeah.
That's wonderful. And I'm sorry, Rachel, can you put that question up again?
I got it. I think, what do
Okay,
I like doing outside of the medical
okay,
field?
okay.
Um, the the unfortunate answer is that like my answer prior to residency would have been exercising um, several times a day, eating healthy, um, meditating, and taking care of myself well. I think that's the thing that if everybody did that number one on their list, if everyone was selfish a little bit and put their health number one on their to-do list, I think
Mm,
the world would probably be a much happier and kinder place. So I think that um, that would
mm,
be my answer. Unfortunately, it's fallen by the wayside for me this last year, just because I have time to do that, but I wouldn't have time to do really anything else, like spend time with my family or my girlfriend or my friends, which that's the main thing that I do outside of residency
mm.
is keep those relationships up because I think those are also very important. Um,
Yes.
I think those are the kind of the three things that I'm deciding to focus on in my life is my health, my
Mm,
relationships, and my work. Um,
mhm, mhm.
but so I
And
think those are the things.
and I wanna underscore another point that you made, and which is that we call it selfish, right? But if we like, "Oh, I it's selfish if I go take an hour to
Yeah,
actually take care of my health," but the
yeah,
truth is, doesn't that benefit everyone? Are
yeah.
like, aren't my kids and my family better off if I'm taking better care of myself?
I absolutely think so. I think that it is a contradiction that is completely true. That the better you take care of yourself, specifically your health, and that I think mental health and physical health, you're going to be a better person to be around. You're going to be a happier person. You're going to have more energy. You're just going to have more patience. You're going to be less mad. You're going to be a better person to be around. So yeah, I do think it's actually helping the people around you if you take some time for yourself.
That's why I love your statement because you said if we do that, then it makes the world a happier place. And truly,
Yeah.
that's just the truth.
Hmm.
That's
Yep.
so true, and it takes the burden off of providers. I just feel so bad for providers having this continuous onslaught. So I know one other thing I wanted to ask you about, which was a really new, because I'm not in that world and I'm not in the robotics world,
Yeah.
but you gave me a snapshot of what is happening in the using robots or developing robots to
Mhm.
do surgery, and surgeons would be remotely controlling. Can you just kind of spell out a little bit for listeners and viewers?
Yeah, so where we are currently, I think the term robots is a little more exciting a term than what is actually going on, which I think will make some people a little happier to know that. But essentially, what we mean when we're talking about robotic surgery now is so um, we have been doing for I don't know how many years, maybe 30 years, laparoscopic surgery, which is when you stand at the bedside of the patient and instead of making a large incision in their chest or that would be thoracoscopic surgery if it's a chest minimally invasive. But if you make instead of making a large incision in their chest or a large incision in their abdomen, you make small incisions and you put instruments into that body cavity, into the chest or into the abdomen, and you operate through those small incisions with instruments, one of which is a camera, so it's showing you what's inside.
Mm,
That's what laparoscopic surgery is. Robotic surgery is essentially this large, um, I mean, it is a large robot with 4 arms or 5 arms is positioned next to the patient bed, and its arms are stuck into those ports, those minimally invasive ports that we already use with thoracoscopic and laparoscopic surgery. Um, and then the surgeon sits in the corner on a console and has great mobility, much better mobility than we normally have with our instruments. Like I think it's like 270 degrees of rotation with your hands, which obviously is way more than our human hands.
Wow.
Um, and it just the movements and the articulation that the robot has are unparalleled or are far beyond the capabilities of a laparoscopic or a thoracoscopic surgery with the instruments that we have.
Hmm.
So it's much more precise, essentially. Um, but the surgeon's still in the corner of the room. I I don't know this, but I mean, at least in anything that I've ever heard of, there's never been a scenario where a robotic surgery has happened with a surgeon not in the room, and I don't think that we're close to doing that. The biggest and most obvious problem with the surgeon not being in the room is if something goes wrong, which does happen, if something is injured, specifically something big that bleeds, like it doesn't matter, a big vessel that bleeds, and you can't get control of it with the robot, then you need to move the robot out of the way and make that big incision to get control, and you need to do it quickly. So that's where we are currently with robotic surgery. I think it's kind of a, a, a fun conversation to have about surgeons operating from around the world or from across the country, but it's not something that has been discussed with any real conviction or any plans that I know of. Yeah, so that's where we're at.
Wow. Well, thank you for that snapshot. And
Yep.
I know you and I agree. We hope there's always a human being around. And
Yeah.
imagine that there will be. And it's nice that I think, I'm probably not the only person reassured by the fact that it's not actually a plan now to just like,
I've never heard of any plan like that. No.
like
Yeah.
yeah, we
I
don't
think
want to speak.
their utility is just the increased control that a surgeon has and the increased kind of articulation. By that I mean like the degrees and the angles that they're able to get with the robot as opposed to the laparoscopic instruments it really is profoundly different. It's also profoundly expensive. I don't know how much exactly the robots cost, but I think it's on the order of hundreds of millions of dollars.
Mm.
If not that, then tens of millions of dollars.
Wow, that is fascinating.
Yeah, so only very big, institutions have them currently. I don't think the outcomes have been shown to be any different um,
Mm.
specifically from minimally invasive surgery. Minimally invasive surgery, laparoscopic and thoracoscopic, the recovery times are less than the large incisions, which is, makes perfect sense. You're making less of an insult, a physiologic insult to the body with those smaller ones.
Yeah, that does make sense.
But not all operations can be done through those small ports, unfortunately.
Another good point. Boy,
Mhm.
oh my gosh, I can only imagine what you're learning, and you're just in your second year of residency. Oh
Yeah.
my
Yeah, I
gosh,
have a lot more to go, yeah.
wow. Well, I know that, uh, one lighter note we can turn to, which, you mentioned, when we were able to talk briefly the other day, which I thought was, like would be a fun thing to comment on, is you said people sometimes they compare, they ask you about, what do you call them, medical shows, like, and,
Yeah,
and you're like, I can give you a
yeah,
little bit of reality check about what's fake medicine and what's real and what's not happening actually. So, and we have, like, about 4 minutes if you wanna just and then
yeah.
I'll be able to say thank you. And, oh, well, there's another question,
Could you
and
tell us
then
about someone you would consider a mentor? Um, I don't yeah. There have definitely been mentors I have in my professional life, um, but not one that really I guess the surgical mentors I've had at my institution are, um, people who have demonstrated that you can be a normal person and a very competent surgeon.
Mm,
Um, Somebody who focuses on their health and their family and is also someone that is well respected around the hospital and the medical community at large. That those are achievable things that won't destroy you. Um,
mm, mm,
that's the those I think are that's the bucket that all the surgical mentors that I can think of fit into. I I don't particularly care how many papers a surgeon has, or honestly, if they're the best technical surgeon in the hospital, if they're not a nice person and they don't seem happy, I'm uninterested in their mentorship.
mm.
Um, so I think that would be those people. There are a couple that come to mind that are those that are enjoy life and are good surgeons, and that's what I want to do.
That's wonderful to hear, and I'm so glad that you stay connected to your people and that you emphasize how important, like, having relationships and maintaining relationships. That's
Yeah,
key to staying well and taking care of yourself.
it is. Yeah.
So, we have a couple minutes if you wanna just, mention anything about TV, medicine shows.
So what we were about to talk about was I cannot tell you the number of times when I tell people that even when I was just in medical school, but especially more so now that I'm in surgical residency, people are saying, "Oh yeah, I've seen Grey's Anatomy," like that. I hear it so much. I kind of want to watch some more of it, so I want to know what they have seen and what they think of what surgical residency is. But you
I've
know,
never watched it. I've never seen it.
um, it's it is not, the hospital is not a drama, unfortunately, or fortunately, I guess. But there is a lot of drama, especially on trauma, like I was saying. Um, there's some quick changes. So I'm sure some of it is accurate, but it's just the interpersonal part. It's just a normal community of people in the hospital. I guess what we deal with is not the most normal, but it's a normal group of people.
Thanks for making that laying out the
Yeah.
truth. Yeah, there's no time. It doesn't sound like there's a lot of time.
Yeah, exactly. Where do we get the time to do all these dramatic things? I don't know. Um, that's the most inaccurate thing. Yeah. What are they doing hanging out, talking about each other?
Right. Well, gosh, Daniel, do you have any kind of wrap up thought, any closing thought or last?
Um, yeah, I do have one that I thought of. I think that what I want to communicate is just that doctors are there to help you. I think that there's um, a movement or a kind of undercurrent that maybe doctors are interested in other things like making money or working with pharmacy companies more so than patient care. And doctors are normal people. There are certainly doctors that are more interested in money than patient care, but the grand majority of doctors are there to help you. And I think that if you go into every doctor's visit with that assumption that they're trying to help you, then you're going to have a better experience and it's going to be a lot more smooth. Everybody's going to be happier and, um, you know, healthcare will move more smoothly. Thank you, Rachel.
True, he is amazing. And much appreciated by us and hopefully more, and I'm sure more, anyone who listened today. And so I just want to thank you again. Thank you so much for giving this much of your time. That's a lot of your time to take. I'm really grateful. And thanks for all the listeners. Thank you for Joe Yackzan and others for your questions. Thank you, Roxy, for all the background work that you do. And to our producer, Dean Piper, always greatly appreciate your work too. And I want to just say, be sure to tune in next Wednesday to It's Your Voice at 8 p.m. Eastern Time on W4CY. You can listen to the radio or watch the show on Talk 4 TV.
Thank you.
Inarticulate speech, inarticulate speech of the heart. Inarticulate speech, inarticulate speech of the heart. Inarticulate